Okay, so thank you everyone, and hello and welcome to the School of Public Health's Facebook Live. Dean Lushniak has a new background this week, which is super exciting. But my name is Kelly Sherman, and I'm a junior public health science major. Sorry, I just took my last final this morning, so I guess I'm a senior. Wow, that's crazy. But and we have a lovely special guest today. So if Professor Roby, if you could introduce yourself, and then also Dean Lushniak, if you could introduce yourself as well.
Hi everyone, I'm Dylan Roby. I'm an associate professor in the School of Public Health in our Department of Health Policy and Management, and I study health reform and health policy. Nice to see everyone.
Great, and I'm Boris Lushniak. I'm a regular on the show. I'm the Dean of the School of Public Health, and it's great having Dylan on, and congratulations to Kelly for finishing your last final. How did it go this morning?
It went pretty well. It went really well. It was one of my favorite classes, so it's really great. But I'm just relieved that it's over with now. And I'm super excited that we have the opportunity to talk and discuss this week. Like, I know it's a very busy week and everyone is lacking on sleep and coffee. So just keep drinking coffee and getting as much sleep as you can. But I'm really excited to be here and see if we have any fellow students who have questions or anything. Please feel free to leave them in the comments on the Facebook Live. And if we don't get to them, as they pop up, we'll have a segment at the end for 15 minutes for questions and answers. So definitely feel free to use that throughout the entire period. And then also just thank you everyone who watched last week's episode on Facebook. And just, again, it's because of viewers like you, and just keep asking questions to make sure that we can answer everything that you would want to hear. So this week, we're going to be talking about different things about reopening stages, and also just different policies that have been in place with COVID-19, what things have to be in place as we reopen and try to return to a new normal. But before we get started, Dean Lushniak, could you catch us up on the past week and everything that's been happening related to COVID, and then also just a broad scope of the situation with policies and stuff?
Great. Well, thank you very much, Kelly, and thank you, Dylan, for joining us. I was just praising Dylan in our pre-show of he and several of our professors at the School of Public Health, working with others, have really spent a lot of time this week working on sort of aspects of testing and contact tracing for the reopening of the university. And so I'm eager to have Dylan, tell us sort of where we're at and the ideas that we have. But usually at this segment of the show, what we talk about is sort of what's going on right now with COVID-19, the current pandemic. And here I always do quote, our neighbor to the north, the Johns Hopkins COVID site online. So right now we're approaching worldwide almost 5 million cases, 4.9 million cases of confirmed COVID-19. And I always put this into the perspective of saying, let's remember that, on December 31st, 2019 was when the WHO office in China was informed of a handful of cases of pneumonias of unknown etiology. And so if you look at the calendar, you realize we're 5.5 months in. This was the new year, New Year's Eve in particular, where this was a brand new disease, and now we're up to 5 million. 1.5 million cases of those 5 million are in the United States. And I think what we've been seeing is a stabilization to some extent in Europe, except for Eastern Europe. And what's happened in the last week is a surge of cases reported out of Russia, and also a continuing surge in South America, in Brazil in particular. And I think that's sort of changing sort of the world dynamics of Eastern Europe now getting many more cases, as well as South America. In terms of fatalities, mortality, and again, we always remember the individuals who have died or suffered as a result of COVID-19. We as public health people always start off with the idea that, it's not just science, it's not just numbers, that these are people, these are families, these are communities that are being affected. And so we have to have that emotional context in public health. But right now we're talking, almost 325,000 people have died from COVID-19 worldwide. Our particular numbers in the United States, as I mentioned, 1.5 million COVID positive people in the United States, and of those, 92,000 deaths that are being reported right now. So we're slowly encroaching on the 100,000 figure in the United States, and it will be reached. The good news, however, is that we're seeing stabilization of some parameters nationwide, and certainly in the state of Maryland, so much so that we're beginning to discuss sort of the philosophies of what's a gated reopening. And the reason we use that term gated is that, and Maryland has been really a good example of not moving ahead too soon unless we look at certain numbers. And we're looking at numbers of hospitalizations, looking at numbers of individuals who have been put into intensive care units, and yes, looking at the numbers of deaths. The expectation is that because we're doing more testing, we are going to get more cases. That's by definition. You test more people, you're going to get more cases. So those other parameters are indicating at least some sort of a stabilization. Most of the recommendations on this gating is basically to say, okay, open up the gate when you get to 14 days of a pattern. And we're now getting to that point of seeing some good positive parameters over those 14 days. So I know in the state of Maryland, we're now shifting from sort of the stay at home recommendation to now a safer at home recommendation. And I actually kind of like that, because the idea is that, by saying stay at home, you're kind of saying you do this, right? This is what we're doing. And many of us, I myself and my family, we've been following those parameters. Safer at home still reminds me that the problem is not over. And we've talked about this in the past. This isn't an on-off switch to say, okay, fine, let's have a parade. It's over, we've won. We've not won yet. We're heading in the right direction. So the safer at home philosophy is now happening throughout the state. But, and this is a big but the governor's given an ability for the counties to look at their numbers. And guess what? Prince George's County, which is where the University of Maryland College Park is located, is still the epicenter within Maryland, right? The numbers are looking better, but they're still not great within Prince George's County. And Montgomery County next door is the same thing, right? And so therefore, those two counties are still not shifting over to the safer at home philosophy. I live in Montgomery County. We're still staying at home because that's what the county has requested of me. News from this week, I would say on several realms, and there's a million things going on. Every day there's a news story, but I'm going to touch upon two things. Initially, we had some information from Korea that people were retesting as positive after having been negative. And there was a fear factor does this mean that the disease comes back? Does this mean that the tests aren't great? What's happening? And there's further data, and this is all science, and things are always, bringing on that maybe those were, inaccurate results on either the first or the second test. And so this idea of turning a negative into positive, yes, there's specificity and sensitivity issues with every test, but at least some of the information is that people are not necessarily getting reinfected a second time. We're still looking at the antibody testing. We still aren't sure if you have the antibodies, whether you're immune. That's still to be determined, but at least that's some good news this week. The other aspect of this week, which, I've been asked to opine, and I'm not self-praising myself, but it's nice when CNN calls and says, we want to speak with the Dean of the School of Public Health from the University of Maryland. But the hydroxychloroquine thing, and what I've actually termed, and again, to our listeners out there, I'm not being political here. I'm being a public health person, and I'm emphasizing the need for concentrated public health education and communication. And so the hydroxychloroquine issue with the president sort of saying, I'm just taking it because, was something that I labeled as completely ridiculous. And again, apolitical, but this is not how we need to be communicating in public health. It confuses the audience, and the audience is the population of our country and perhaps the population of the world. So right now we're spending a lot of time sort of pulling that back, saying, no, this is, yes, it's a medication that's been used for various reasons for 40 years, but it has a safety profile, and you can't just take it because, right? Let's wait on the science. If this proves that it helps to prevent COVID-19, fine, but wait until the science is there. So that's an example of late breaking news. On the university front, and Dylan, I'm sure will share more from his committee's perspective, is we continue to work very hard with sort of the phased reopening of the university. Um, so all the committees are full action, right? Nonstop. I mean, it was working throughout the weekends, spending late hours on meetings and rewriting task force reports. And we're looking now at a phased reopening of the university that will occur over the summertime. And that the details are still to be worked out. But again, the prime mover on this is the health and safety of everybody who starts coming back, and aligning ourselves with what Maryland as a state is telling us and what Prince George's County as a county is telling us. But there's many facets to this, and we can discuss it when we ask Dylan sort of questions about where we're heading on various aspects. But that's kind of the news report for the week. And so, yeah, always, stuff happening out there, but the disease continues. There is some optimism, but let's be careful.
Thank you so much, Dean Lushniak. And also, don't sell yourself short. CNN's reaching out to you because you're a professional here. You should take pride in that. But just going off of that and talking a little bit about different legislation, and you were talking about state and federal government and stuff. Professor Robbie, could you talk about like the different pieces of federal legislation that's been passed and what they entail and how they can specifically help state and local governments?
Sure. So, I think, in the US, we're familiar with kind of our federalist government system where a lot of the decision making related to funding and broader policy decisions might be delivered by the federal government, but really it's up to the states and counties to roll it out and implement something that meets their needs. And sometimes that's a great thing because it allows states to kind of deal with their needs. And other times it results in, guidance coming down from the federal government without a lot of teeth to it. So we've seen 3 different pieces of legislation pass. A 4th one is in the mix right now, and it has passed the House on a pretty narrow vote, 208 to 199. And it is basically dead on arrival in the Senate, according to Mitch McConnell and President Trump, who said he would veto it. But in the first 2, so the few that passed, one of the bigger important ones was the Family First Act, which provided it wasn't the big money bill that created all the small business loans and the larger unemployment bumps or the $1,200 check that taxpayers got. It was an earlier step to that basically wanted to provide some guidance around family leave and sick leave, and saying that COVID sick leave is appropriate and that it would be paid for. It also provided grants to states that might have unemployment rates over 10%. With $500 million going there. So, and it also expanded money for Medicaid. So in the first Families First Act, states with Medicaid programs got an extra 6.2% in federal matching funds, which was designed to kind of shore up the Medicaid program temporarily because everything was very unforeseen. They didn't know the costs of treating COVID at that point. The CARES Act is the one that we've heard about a lot more, and that was about $2 trillion bill. And it's the one that included $150 billion for public health response. It included the $1,200 stimulus check that people got who earned less than $200,000 a year as a family, or $115 as an individual. It also increased unemployment, so it backed up state unemployment funds and gave. But I think one of the core elements was that $150 billion for public health, as well as state and local funding to shore up public health and COVID response. Since then, the counties and states have been a bit concerned because the bill actually included language that said that money has to be new spending related to COVID, and it couldn't be used to fill in budget holes that were created by huge unemployment increases, lack of income tax revenue coming into the state. So in essence, by having this stop on economic activity, states have been unable to rely on the revenue they were expecting from taxes and, sales tax, income tax, et cetera. And they were spending a bunch of money on the public health response. So the next version, so that passed, but states are complaining a bit about the inflexibility of that law in allowing them to spend on fixing budget problems that were created by COVID. And so the HEROES Act, which was passed by the House and is likely not to pass the Senate, and is a $3 trillion bill. So we're getting past, we're getting into the trillions now. So the difference between $2 trillion and $3 trillion doesn't seem like that much because it's just one number, but it's a much larger bill. It includes things like a $500 tax deduction for first responders and healthcare workers. It includes more money for kind of hospital bailouts for those who haven't been seeing COVID cases, but need money just to stay open. It includes $875 billion for state and local governments. It includes another round of $1,200 stimulus checks, more Medicaid funding. However, one of the issues is that the HEROES Act tries to address is this problem in the CARES Act where counties and states can't use it to fill budget holes. And it includes language that says that would be possible. So you could fill a revenue gap that was created by COVID with money from the HEROES bill that isn't allowed in the CARES Act. So a lot of state and local governments have been pushing for that. Mitch McConnell has said, I think counties and states that have those budget problems should just file for bankruptcy. And so that's a non-starter for Democrats in the House. And so we're likely to see a really large stimulus package that includes more testing money, public health money, as well as state, county, and local money. However, Nancy Pelosi as the Speaker of the House and Mitch McConnell as the Senate Majority Leader are going to fight over those details, and they will have to put something together that President Trump will sign. So that's kind of pending at this point.
Thank you so much for that. And just going off of your point about like different money being set aside for public health practices and stuff in policy, how can policymakers like enact these public health changes for the future and implement them in everyday practices?
I mean, that's a difficult question. So one of the problems is public health has historically been underfunded. And part of the reason for that is when public health is working well, people don't perceive a need for public health. So, we haven't needed wide-scale testing and contact tracing activity and the ability to share data easily in a big crisis like this for the past 100 years. And because public health and sanitation and clean water has been working very well in the country, there isn't a perceived need. So when we see health-related legislative packages and budgets at the state, local, and federal level, most of the budget allocation relates to actual healthcare services. So like long-term care and skilled nursing and inpatient hospitalizations, and we don't invest in prevention. The ACA included money for a prevention and public health task force. It included legislation or packages around limiting cost sharing for preventive services. But people only know that Public Health and Prevention Trust Fund as what Republicans labeled Obama's slush fund. And so they attacked it in every subsequent budget cycle because they didn't feel it was important. So even though counties and states could have bolstered their public health infrastructure, staffing, computer systems due to the Affordable Care Act, which passed in 2010, a lot of the money they were guaranteed went away because of subsequent budget holes that the federal government was trying to address. And so we still ended up with this underfunded public health system. Now you have a crisis and everybody's in this mood to ramp up, but it's pretty late in the game where we don't have the workforce that's flexible enough to deal with some of these needs. And you need to either hire consultants or hire an army of contact tracers and people who are savvy with technology to do this work. And unfortunately, it's very difficult to do quickly within the budget, even if the budget is there. So the hope would be, legislators like to solve problems or at least perceived problems. So if public health is now a perceived problem and, rampant pandemic is a perceived problem, maybe we now have the policy window to basically say, look, this is an important issue beyond just healthcare services. We need to make sure we're preventing outbreaks and ramp up our global health capacity, ramp up our investments in prevention and public health infrastructure so we can monitor and deal with these issues. So my hope is that we come out of the end of this with a stronger public health infrastructure because of these investments. But these are temporary bills. Like, this is spending that's all occurring in the next year or two. And so we'll really need to make the case that that spending needs to go forward, and build it into our federal government and state governments, rather than assuming every time we're going to have these emergency response bills that end up filling the gap. But we're always going to be behind if we act that way.
Let me, Kelly, add to that. It's kind of interesting. Dylan brought up several things that sort of, innately, make me break out in hives, because I actually had firsthand experience with that. And, you mentioned the Affordable Care Act and specifically the Prevention Fund that was part of it. Between 2010 and 2015, I was in the office of the U.S. Surgeon General as acting U.S. Surgeon General for a year and a half, but also for those 5 years as Deputy U.S. Surgeon General. We actually ran the National Prevention Council, right? And had a strong sort of belief that this prevention fund was going to be used exactly for the purposes that Dylan talked about. We thought this was going to be the heyday of prevention, health, wellness, public health, that there finally was a recognition of its importance. And in those 5 years, I kind of saw, the reality. And the reality is that unless we really change a perspective of viewing that health and wellness and prevention is really important all the time, then it's a small matter, to sort of say those words, but it's a bigger matter to actually implement that philosophy nationwide. And what we saw in those 5 years was exactly what he described, was a prevention fund set up. I think the initial numbers were like 1.5 billion, right? It wasn't a huge amount, but ultimately it was then used for multiple other things. It was something that when you ran out of money on something else, let's go to the prevention fund. Psychologically, that shows you what? That nobody really cared from a policy matter that this was that important. We do have an opportunity right now. And it's not just, kind of a sense of, well, look at us, look at what we're doing, we deserve this. It's a sense of us being educators for policymakers and saying that, yes, we're here in the middle of the crisis, and look how much better we could have been had we been prepared. But also, as I keep saying, guess what? There's a public health crisis going on each and every day. It's not on the news. It's not necessarily being reported. And then list our top 10 problems in public health. And those are crises, right? Diabetes, overweight, obesity, cardiovascular diseases, opioid, right? Addictions, right? Those are just a handful of things, right, that exist each and every day. And what our listeners and viewers should know is that we as a School of Public Health are part of a larger entity. And that larger entity is an association we belong to. It's called the Associations of Schools and Programs in Public Health, ASPPH. I happen to be right now the chair of the advocacy committee of that organization. And one of the big pushes we've been doing, and it's exactly what Dylan was saying, is that as a group, right? And so these are schools and programs of public health. So they're fellow deans across the country of schools of public health, and those who direct programs, MPH programs who aren't full schools. But we all get together, we all talk about this. And from an advocacy aspect is we realize the government is spending lots of money to solve a problem. We can't allow the government to ignore public health, not just in the short term, but in the long term. And so right now we have to view this as this is an opportunity for education of policymakers of where public health fits in.
Thank you, Dean Lushniak. And going off of that, in terms of like local and state governments, I know Maryland, for example, like Governor Hogan has given the orders to open the state. However, there have been certain counties that have tried to remain closed. How can county actions help prevent the spread if individuals from maybe other counties may still be allowed to travel throughout that county?
I mean, so we don't, the U.S. is built upon, porous state and county borders. So there's not really a way to control people's movement. I think the best way to deal with that is through increased surveillance in terms of testing and making sure we're catching asymptomatic cases, and also making sure that people know why they need to wear a mask and why they're being asked to be compliant with certain requirements. I know I saw that when Georgia kind of reopened, there was the University of Maryland team that looks at cell phone GPS traffic basically showed that there was an influx of people coming from bordering states to use services. So we need to balance the issues that people feel in terms of the need to use services, get to work, et cetera, with public health concerns. But I think we've probably done a poor job relatively in terms of explaining to people what behavior is really dangerous and what is not. I think, as Dr. Lushniak mentioned, we've just been, the stay-at-home orders kind of give this like, do not do this type of approach. And we haven't really been helpful in disseminating evidence out there about what might be safe. Like, there's not a lot of evidence around outdoor spread of coronavirus. So maybe we shouldn't be shaming people who don't wear a mask out in public when they're jogging. We should instead be saying, look, in indoor settings, if you're exposed for 15 minutes or more, you're much more likely to get this disease. And that's why it's important to have a mask on. And then maybe you would have fewer issues about people claiming that their rights are being violated by having to wear a mask, because they're upset about this broader perception of people intervening and government telling them what to do and regulating their behavior.
So with like mass communication about different public health knowledge, just what are some ideas for like the best sources of information for these like different educational tools to be broadcasted?
So the dean is much better communicating than I, but I would say, Twitter, Facebook, Instagram are all venues that people use and can quickly get out a message. The problem, of course, is there's lots of misinformation out there as well. So it's kind of up to us as public health professionals and academics to help people translate that information. And that's something that doesn't happen overnight. We as academics and schools of public health are often told like, well, your article is going to sit on a shelf and collect dust, or, people are just going to read it for the sake of research. And we really need to do a better job of making sure that it's delivered to the right places, that the findings are translated for media outlets, and synthesizing that information so information can be disseminated. So with the hydroxychloroquine issue, people don't really understand the process of creating an evidence-based guideline, and it's reliant on randomized clinical trials, which are considered the gold standard of research, and then multiple randomized clinical trials resulting in a meta-analysis or systematic review to back up that recommendation. And we can't just use one study to decide to do one thing, because there's a lot of error that occurs in those studies. But it's created this distrust of researchers and distrust of academia, because people say, well, I always see on the news that this study was debunked, when in actuality, the evidence is actually driven by the body of work rather than one specific study. So we need to do a better job of translating our research, but also limiting the inability to misuse it, I think, which could be very dangerous.
Yeah, and I'm in agreement. I mean, so what we have to really do is effective health communication in the midst of a crisis, and even effective health communication not in a crisis period, is contingent upon several things in the 21st century world. It's multimodal, right? So it's no longer the evening news or a commercial on TV. It's no longer what it used to be, was an ad in the newspaper, right? What we realize is that, our world now relies on communication from a variety of sources. So you have to saturate all those sources. We also have to take into account the sense of health equity and information equity in the midst of this, right? We talk about, the Twitter, the idea of Facebook, the idea of, well, not everybody has access or has that. And the question is part of our health equity issue when it comes to COVID-19. Underserved communities now are higher in terms of number of people affected, percentage of people affected, mortality. So the question is, how do we understand a community so we understand how that community communicates, right? And I think this is where we use sort of the concept of a community health worker. And the community health worker doesn't have to be a full-time position. It could be a member of the worship and religious community. If they have access to information that I give them, and it's factual access that saves people, I can use them as being communicators for that community. The problem that we have, Kelly, I think to a large extent with this is, I keep saying, in the midst of this COVID-19 pandemic, If the three of us sat down and wrote a book or wanted to write the ideas for a movie, and we kept throwing the inserts of everything that's been happening with COVID-19, most people would walk away saying that this is not in the realm of possibility, right? And let's begin with the idea of how communication at the highest levels here have not been working. Because what you do need somebody with authority and understanding of the science speaking out and says, here's what we know, here's what we don't know, this is what we're trying to do to find out what we don't know, and here are our recommendations and guidances under the conditions of what we know and what we don't know. And to speak with authority, to speak with a sense of, yes, we're never perfect and things may change, and not to induce doubt in people. In other words, transparency, here's what I know, here's what I don't know, but this is the best information I can share for you, and be consistent in that communication. That then leads, right, to infiltration using all these modalities of saying, okay, here's what is being said. There's always going to be naysayers and doubters and people who believe in conspiracy theories. That always happens. That happened 100 years ago in the midst of the pandemic of 1918. The reality is that's never going to go away. But if we are consistent in our messaging, and what we've seen here with COVID-19 is, who do we believe in anymore, right? The CDC, I spent 16 years of my career working at the Centers for Disease Control and Prevention, has usually been the leader of this. And in this case, all of a sudden, everybody knows the press is covering this. The CDC has been sidelined, totally, right? So if it's not the CDC, who's my information given? Well, certainly we look at Tony Fauci at NIH, he's been out there, but at times he's giving information and then someone else, i.e. the president, is giving information. So this has become kind of that strange nightmare of really doubt seeding throughout a community. Who's right? So I think, to your question, it's really multimodality, but we really have dug ourselves a big hole because there's so much doubt in information right now. And I appeal to our viewers here is, fact check everything you're reading, right? And in the day, I would have said is look at the CDC site because I have a trust in it. I still have a trust in that CDC site, but you have to dig deeply to actually look at, and CDC has not been updating necessarily on the timely fashion, nor have they been speaking with the public. I mentioned I spent 28 years in the federal government, right? In the midst of every crisis in the past, CDC had a daily press briefing, not necessarily for the public, but a daily press briefing, right? Where they would sit down and tell the press, the gathered people from all media, here's what we're saying. That now has been diverted to what's, in essence, a mixture of politics. It's a mixture of science. It's a mixture of hearsay. It's, that's not how we would teach at the School of Public Health how you communicate in the midst of any crisis, much less a worldwide pandemic like we're seeing. There are mistakes being made.
Thank you so much for sharing that insight and just talking about health communication. And I guess going off of health communication, just factors that would need to be implemented during a pandemic or during regular life, what other factors should we have in place so different towns and cities and even College Park could open again?
So I think one of the big issues you've probably heard is kind of this idea of testing, contact tracing, and isolation. Because a lot of the reaction to COVID-19 came on a little bit late, in some areas a lot late, the capacity to do testing is still catching up. The capacity to do contact tracing is now catching up with that lack of testing. And we don't have a social safety net or investment in social services that really allows us in any state to do effective isolation like you might see in South Korea or Singapore. Because they're able to basically have people staying in quarantine quarters, supported by public health staff, receiving public benefits, not losing their job, and being able to recover without exposing other people. In the US, we're basically catching cases after they've become so symptomatic that they could result in hospitalization. then issuing a test. When we're doing contact tracing at that point, folks have been potentially symptomatic for between 7 to 14 days. And even before that, they were likely a disease spreader. So it's very hard to do contact tracing for that many people and really follow up on everything that's happened. And then we're not isolating people. If they're lucky enough to get admitted to a hospital to get care, they are isolated. But there are a bunch of people who have serious symptoms, who have very low oxygen levels, and are still being sent home to self-quarantine with their family in the home. So we have a lot of gaps in that ideal process. I think one of the first things we need to do is not assume that we're so late in the game that we should just let this burn out on its own. Instead, start investing in testing and tracing immediately. And I think some of that is being done at the county level, but there's still huge supply chain problems in terms of swabs, purchasing tests that are FDA approved, things like that. And it's a lot of money. So like the White House said the Abbott Labs test is great and has been using it every day to catch cases. It's very slow and it is very insensitive. So it's 48% sensitive. So it's only catching 1 in 2 cases. And that isn't a feasible strategy for large population surveillance. So I think we need to set up testing capacity that allows us to catch asymptomatic cases. And I think that comes in surveillance. And one of the ideas that we're considering at the School of Public Health, and that came out from Stanford, is the idea of doing pooled samples where you take 10 to 20 sample tests or tests, put them on the same PCR plate, and run the test all together. So you end up with 10 or 20 in the same pool. And if you get a positive hit for that pool, then you test each individual one. But if you're like us, where we have in the state of Maryland a 0.6% prevalence rate, it may be kind of too late to do that because you have a high likelihood of having a positive pool, and then you end up retesting everybody and spending more money. But if you have high risk folks like grocery store workers, postal workers, factory workers, meatpacking workers, et cetera, you could do this sort of surveillance testing using more efficient means rather than requiring them to get an individual test, and be able to do this in a way that allows you to isolate certain populations when you get a hit and then follow up with an individual test that's able to actually see if they have the disease or not. So thinking creatively like that is going to be really helpful. And, the model that we've been following, which is go to the doctor, be seen and triaged, be told, yes, you have COVID symptoms, but because you can still breathe, we're not going to test you. Go home for 2 weeks and hopefully you get better. And if you have a problem, come back. That is not an appropriate public health model. That is, an emergency model based on the lack of supply and testing. And that is really going to be the cornerstone of being able to reopen, because we need to know how much disease is out there, and people who are asymptomatic, which represents about 50% of the positive cases at this point, need to know that they need to quarantine as well, instead of waiting for symptoms to occur.
Yeah, I think that this is important, right? And this is a great segue to talk about sort of university matters as well. And Kelly, you and Dylan are on a committee, right? And Kelly, you should actually tell us a little bit about your perception of that committee shortly. But as we're looking at the big university, and I know many of our viewers want to know what's going to be happening. Well, in the next few weeks, there will be an announcement. I'm not sure at this point what the announcement is going to be because we're still working yet. From a public health aspect, it really is. It's dependent on first what the state is telling us, what the county is telling us. But already we know that any kind of reopening will mandate us having a system in place that deals with symptom surveillance, deals with a testing component, deals with contact tracing, the use of masks, disinfection and hand cleaning, and then physical distancing, right? So we know that those are, sort of the components of it. But that being said, that's kind of where we're thinking and heading. But Kelly, you get to ask the question. So let me ask you a question. As you're a student representative, and tell us a little bit about your experiences on this committee that you're part of.
Yeah, thank you so much. So actually, I'm on the committee with Professor Roby as well. And as a student on like one of the health and wellness committees, so this is one of the 4 subcommittees that reports to like the life advisory committee to give recommendations about how the campus should reopen. There are just like lots of different things to juggle when it comes to health and wellness and opening the campus. So I think it's really important that we do have student voices heard at the table, but also like it shouldn't just be my own voice. I think like we should be reaching out to students and faculty and like making sure that people like feel represented and also like just feel heard and like understand like their emotions are valid during this time, because like if you don't feel safe or you don't have a perceived belief that you'll be safe at the University of Maryland, then you wouldn't want to come back necessarily. So I think it's really a great committee to have a student representative on it, but also like we should be keep getting as many more like voices from different students and faculty members. And then speaking about student and faculty members, and thank you for asking, but we could jump into our questions submitted by listeners right now. So one question submitted, it's from Joanna Romero. She asked, is herd immunity not possible if people are being reinfected? So I guess I'll direct that to Dean Lushniak.
So, the concept of herd immunity. So, it is a potential pathway, not necessarily the one you want to take most directly, because what is it predicated upon? It's predicated on putting the whole population at risk and at allowing not only morbidity, sickness, but in essence, mortality, right? And so, yes, one approach is, and this was discussed mostly in England early on in this pandemic, is okay, let's do nothing. Let's allow everyone to get sick. We'll accept that a certain percentage of the population will die. We'll accept that others may get ill. The hope is most will have, minimal symptoms. But we also know that certain people get really, really sick and may have further repercussions. That ultimately leads to what? To you having to deal with that decision point and the repercussions of that decision point. Ultimately, does it protect the population? We use that term herd immunity. People sometimes don't like it because it uses us as almost animalistic, right? Herds are not people, herds are cattle. But the reality is we are, part of a larger community, and maybe it should be referred to as community immunity, to make us sort of, more accepting of it. But to use that as the only public health approach is not the right way, because it's going to inflict pain, suffering, and death upon some subset of the population. A lot of times we'll use the term herd immunity when it comes to vaccine programs. How much percentage of the population needs to be vaccinated as a preventative to be able to assure that that population is somewhat or is protected from that disease. So when we talk about herd immunity, you're really talking about figures of minimum of 60 to 80% of the population having been infected before you begin seeing any potential positive out of that. And with many infectious diseases, when it comes to vaccine, it's really 90% or above before you sort of feel safe. But we are part of a community, and it's one of those things where when you look at the future of COVID-19, right, short of a full successful vaccine, that ultimately, if this sticks around for long enough, there may be an aspect of herd immunity that happens despite everything that we're doing. It'll be a very much different approach, because what we've been trying to avoid here, you remember that old saying of flatten the curve, was us having an extreme surge of everyone being sick at the same time. And that would overwhelm our medical care system, that would overwhelm our emergency rooms, that would overwhelm our emergency departments, and our intensive care units. That's what we were trying to avoid. So herd immunity, the discussion still continues. We don't want to use that as the primary public health reaction to this.
Thank you. And then we have another question submitted. So this question is from Jean Sherman, and she's asking, are the students going to be tested when they return back to campus?
I think at this point that is unknown. If we're up to me, I would probably encourage anyone who was, or encourage the planners to at least test everyone who was coming back to reside on campus, because the dorms could be a very, a sensitive spot within the university. And, students are coming back far and wide. So some could be coming back from their home in New Jersey or New York, where there has been a lot larger level of spread with, 1 to 2% of the population getting it, and the health system's overwhelmed in some cases, and some folks are coming from other areas. So I would think that a successful reopening plan should include some level of testing for everybody returning upon reentry, and then periodic surveillance after that.
Awesome.
And let me add to that a little bit as well, is that right now, we again are part of a larger body when it comes to this. So we, University of Maryland College Park, are part of the University System of Maryland, right, which includes all the schools under the University System of Maryland. And initially, the sort of the guidance from that larger group, we have a new chancellor there, Jay Perman, who's very well known to us, formerly from the University of Maryland, Baltimore. He's a physician. So he understands this rather well from that aspect. And they actually sort of said, as part of the plan for reopening, and this is to all the schools and universities, is to have a testing program in place. I agree with Dylan. Right now, it's premature to tell us exactly how that's going to work. Is it everybody? Is it some subset? Is it based on other things? Is it once? Is it recurrent? We still have to work through the details, but there is going to be a testing program available to faculty, staff, or to students, staff, and faculty who are returning to campus.
Thank you. And then another question is, how do we prevent statewide spread by opening up county by county, especially considering how interconnected the DMV is? And this is from Francine Baker.
I mean, I think, as I mentioned earlier, it's very difficult to limit county spread. There are, so really it becomes an issue of understanding the underlying burden in your community and doing testing. And I think one of the big problems here is just screening based on symptoms only catches half of cases. And if we're just screening for certain symptoms, like fever, for example, we're catching even fewer cases. And, as the evidence mounts, being exposed to people in indoor settings for longer periods of time, like 15 minutes, gives you a higher likelihood to be exposed to the viral load that'll likely make you sick. And so we need to be very careful about saying, okay, well, we're not going to set up a police checkpoint at the border of a county to prevent people from going to their jobs or congregating outside if we feel that is safe. So I think we really need to develop a strategy that's based on evidence rather than assuming that disease spread could occur in settings that actually are fairly low risk. And the concern I have is, if we're limiting travel too much and focusing on these low risk environments, people are going to become fatigued by that level of guidance and lockdown and the perception of not having choices. And then we're going to see a lack of compliance across the board for all of the behaviors we want people to engage in. So we really need to be clear about what the evidence says, strategize about what the most effective ways to prevent spread are, and focus on those areas rather than and kind of keep up with everybody when it comes to cabin fever and this interest in being outside, seeing family, seeing friends, going back to work, and those sorts of things.
Thank you so much for answering that question and just like reiterating different things that you've said earlier. So that looks like all of the questions that we've gotten submitted in live time. So thank you everyone who submitted a question to us. And if you have more questions or anything, like, please feel free to leave it as a comment and we can try to address it next week, or email the School of Public Health and we can get to it. But also thank you so much, Professor Roby, for joining us for this segment and just like talking to students like on a very approachable matter about a very heavy topic that's happening right now. And then also thank you so much, Dean Lushniak, for taking the time out of your day. I know it's not as glamorous as CNN, but we're still important.
Thank you, Kelly.
Thank you so much. Actually, you asked better questions than Wolf Blitzer, but don't tell anybody.